yellow knife, yellow whatever.
Yeah, I think you could be live. You could be live right now. Good chance. Yeah.
We're good?
Mm-hmm.
Hello, everybody. Welcome to Fertility Fact or Fiction, the show where we dispel all the myths and expose all the truth. So welcome back. We hope you had a great long weekend if you're in the States or in Canada. And for those of you who will subsequently join us for Europe, we hope you had a wonderful day as well. It was a brilliant, warm, hot day today, and many thanks to my good friend Allison and Aaron, who took us out surfing yesterday. That was awesome. No, I cannot surf with 2-foot white caps in the water, but it was fun trying anyways. So great to be back with you all. We have a show that a lot of people wanted to know about, which is whether or not human growth hormone can actually positively impact your cycle, especially for those that have diminished ovarian reserve. So hopefully you've got what you need to join us. Grab a coffee or a tea or a hot chocolate or something fun and something to munch on, and we're going to get right into it. We usually spend about 15 minutes just going over the topic at hand, and then we answer your questions live. So if you have any questions, you can start putting them in now, and we will happily address all of those for you shortly. And we address them live on the show, so you can ask now and we'll answer you in real time. So the topic tonight was human growth hormone, and the title of the study that we're going to look at, although there are many studies, was growth hormone co-treatment for poor responders undergoing IVF, a systematic review and meta-analysis. So this is the latest of a long series of studies looking at human growth hormone to determine if human growth hormone actually positively impacts your outcomes. So this has been going on for a long, long time. As far back as the early 90s, people were trying to explore whether or not co-administering growth hormone with the other FSH and LHs that we use, like Gonal-F and Menopur and so on, could make an even bigger difference and give you a better chance of success. And so early on, there were many studies that showed that it did, but then since then, several randomized controlled trials have been done with varying results. So this study pooled all of those studies together, including a very critical, well-done study that was published in Reproductive Biomedicine Online in 2020, which was a direct randomized controlled trial, double-blinded, where they made sure that everything was equivalent. They gave half the group the human growth hormone, they gave half the group placebo, and they checked to see whether or not it actually made a difference. And that trial really kind of altered things to some extent for the literature up until that point, although again, there were several studies going back and forth when they amalgamated all the other data together in terms of whether it worked or not. So this study is from an Italian group, and they just compiled other data together, and they wanted to see what the chances were. So altogether, they looked at 230 different journal articles. They limited that down to 20, and then they ended up with 12 after they removed the ones that just didn't meet their criteria. From the 12, they found 1,139 patients that were classified as poor responders, and they had 586 that were in the treatment group getting growth hormone, and they had 553 that were in the control group that did not. And all of these were from randomized controlled trials. So these are the best studies we have that are available to us. And essentially, they looked at a number of different things. So they wanted to see live birth. They wanted to look at miscarriage rates. They wanted to see how many eggs you produced, how many were mature, and how many turned into usable embryos. So there were a number of different factors that they were exploring, and some of the studies had some of those bits of information in them. Some of them did not, but they included everything so we could give you kind of the most robust data possible. So we're going to go to figure 1 and we'll show you that. And figure 1 is kind of the meat and bones of this because that's the one you all want to know about. So figure 1 is, does it actually make a difference in the live birth outcomes? In the clinical, my apologies, in the clinical pregnancy outcome. So this is seeing a heartbeat, but not necessarily ending up with a live birth. So they included many of the studies. Unfortunately, the Norman study, which was the one from 2020, did not have data on that. So that didn't make it into this part of the equation. But if you look at the bottom, you'll see that little diamond kind of flipped over on its side, turned 90 degrees. And that diamond is to the right, if you're looking at the screen, of the actual line that divides the control group from the growth hormone group. So what this means is when they analyzed it, there was a 34% increase in the chances of seeing a clinical pregnancy. So you would get a live fetal heartbeat, not a live birth, but a live fetal heartbeat at your 6 or 7 week ultrasound. So this looks really hopeful and kind of makes everybody think this is wonderful. Maybe this stuff actually works. So based on this, you have a statistically significant increase in clinical pregnancy rate if you use the growth hormone leading up to the treatment and through the treatment up until egg retrieval, but it's exclusively for the clinical pregnancy rate. So we're going to go to figure 2 now. And in figure 2, you will see that they actually explored the live birth rates. So for the live birth rates, they included that Norman study, but then they excluded some of the other studies because they didn't have information on live birth. Why is this important? It's important because live birth is the holy grail of all things that we do. It's great to say you had a biochemical pregnancy, you had a positive beta, you even had a clinical pregnancy rate. But if we're not ending up with an improvement in the live birth rate, we're really not doing anything useful. And so it's always important that we make sure we know what we're talking about in terms of our outcomes, because you want to make sure that you are dealing with the outcome that is right to be analyzing and the outcome that makes sense in terms of what we communicate to you. So when you look at the live birth, you'll see that that diamond is crossing the bar that divides the control group from the experimental group. And again, there was a 34% difference, but because that diamond crosses, this is not statistically significant. In other words, there is no increase in live birth when you are using growth hormone. So we get asked this in many different shows. I've been asked it clinically multiple times. I have tried using growth hormone in the past. In fact, I have one patient that wants to try it now. But the rationale has always been, look, the data does not support an increase in live births. Now, as soon as we posted this last week, we had one patient that jumped on and said she had tried many IVF cycles before, but she finally got some good embryos and she finally had a good outcome. And you know what? I'm thrilled to bits that that was the occurrence for you. But when you're looking at this from a randomized controlled trial data perspective, it does not look like it improves your live birth rates. So now the third figure dealt with 3 different elements. So there's A, B, and C, and we're going to show you figure 3A right now. And as you can see in figure 3A, they did see more eggs being produced. So the total number of eggs, there is a 62% chance of having, or 62% higher chance, I should say, of having more eggs. So that's a really good outcome because this is telling you that there is a higher number of eggs that are going to be available for you to use. Now, does that translate into live birth? Unfortunately, no. But keep in mind, some of these studies are coming in and out of the analysis. So you'll see there the different names that are graphed there because some of the studies had this data, some did not have this data. So importantly, you are seeing an increase in the number of mature follicles, but you're not, or sorry, a number of follicles, but you're still not seeing an increase in live birth. The B group is the number of eggs that were mature. In this case, you have a 106% chance of having an increase number of mature eggs being developed as well. So that's again really important because we need your eggs to be mature in order to be able to fertilize them. So there may be certain circumstances where maybe this is more beneficial. Someone who tends to recurrently have more immature eggs, this may somehow nudge that forward for us. And then the final group was the number of embryos that they had to transfer. And unfortunately, this one was not statistically significant. So they did not see a difference between the control and the experimental groups in terms of the number of embryos to transfer. They also analyzed the miscarriage rates, and it wasn't put up in a graph, so I don't have one to show for you, but they did demonstrate that there is no difference in the miscarriage rates. So ultimately, is growth hormone helpful for your IVF cycle? Well, the reality is it is not helpful in terms of increasing the number of live births. And certainly the best done of all of these studies is the study by Norman from Reproductive Biomedicine Online in 2020. And that study did not show a statistically significant improvement in live birth rates. This study, amalgamating all of the other studies that were validated for use here, also again does not show an increase in live birth. You may have more eggs, you may have more mature eggs, your clinical pregnancy rate is increasing, but some of those are dropping off either because they're abnormal or there is a miscarriage or whatever the occurrence is, and they are not going on to fruition to result in a live birth for you. Now, does it have any risks? None that we really know of, other than it's very good at rapidly draining your pocketbook, because it is quite an expensive drug, and there are no studies to absolutely support continued use of this. So at every conference I've been to, we always talk about the poor responders. I love attending those sessions just because I want to see what other people are doing. We've had loads of people swear by it and say they use it all the time, and then you get the other person in the group that says we tried it and it doesn't work and we've gone back to other techniques. So there is no single technique that will work for everybody, and certainly growth hormone may work for some people, it may not for others, but overall, when you analyze this in a statistically appropriate manner, it does not appear to be increasing your live birth rates. And so in my mind, it makes a lot of sense to save your money, spare yourself from having to spend all of that, take yet another injection and shot, and just use other treatments or approaches, even something as simple as repeating an IVF cycle, where really it's probably only going to be a little bit more than the cost of the drugs. Now, certainly if you have coverage for growth hormone, that changes. But if you don't, you're investing a lot of money into something with no proven benefit. So thank you for joining us for the Fertility Factor Fiction. It is a fiction that human growth hormone will increase your live birth rates. It is a fact that it does not, according to the most up-to-date data and the most recent studies. And there are multiple studies that support that same assertion. We're going to take your questions live now. So if you want to start asking your questions, or if people already have been, we're ready to go. And thankfully, Tarek is here with us again. So big round of applause for Tarek. We love him, and he's going to ask the questions.
What are your thoughts on trying again after taking methotrexate for ectopic pregnancy in unknown location?
Sure.
How long should one wait?
So you need to wait so it's methotrexate, which is a low-grade chemotherapy agent that we use. And you should wait until your betas go down and stay down for at least 3 weeks. Beyond that, overall, we usually tell people to wait 3 months for it to wash out of your system, because it does antagonize folic acid. You need folic acid to make DNA. Obviously, your baby is producing tons and tons of DNA, and so it will very significantly interfere with that process, which is why it's effective for ectopic pregnancies. So we would strongly advise you to consider waiting at least 3 months, but also you have to follow your betas down and make sure that they get down to 0.
Why do I have vaginal itching about 2 weeks before getting pregnant? Is this hormone related?
I don't know why. I'd have to analyze you. We'd have to do studies and so on. There are women that get itchy around the time, if it's 2 weeks before you're getting pregnant, that should be right around the time of your period. If it's around the time of your period, you may be sensitive to your pad or your tampon. Many women are. There may be constant cleaning, which can irritate. There may be alterations in the bacteria. So vaginal itching can have a lot of different sources. Almost always number one is just contact irritation. So a lot of women are sensitive to their pads and tampons and don't realize it until they switch out. So make sure you use one that's unscented. Make sure you use one that's hypoallergenic. Sometimes women even use a Diva cup so they avoid all of that irritation. So there's a variety of different ways to handle it, but try something different and see if that gets rid of the itching? Great question. We've never been asked one like that before. Yeah.
Does ovarian rejuvenation work?
So we just reviewed that on the show a month ago. So PRP injections into the ovary did not appear to work until about last summer, where one study came out showing that it may improve success rates. So it took women with no previous success, and when they injected PRP, the platelet-rich plasma, into their ovary, it got them somewhere between an 8 to 11% success rate. It was not a randomized controlled trial, but it was involving someone that I definitely trust scientifically. That's Richard Scott. And so it may be beneficial. It's kind of hard to justify when the success rate is that low, but if it's worth it to you to try, it can be done. And in theory, it should be harmless because you're just taking your blood and injecting it back into you. It does require IVF. We got to stick a needle in. We got to stick a needle into your ovary, which is pretty small if it hasn't been stimulated. And then we've got to inject that PRP, which has left your body and is now going back in. So there are infection risks, there's bleeding risks, injury risks, and so on, but they are pretty minimal, and it is possible to do to see if it will improve your chances.
Is it safe and posing no threat to the frozen embryo transfer to pick up and carry your toddler after the transfer?
That's a great question. So we definitely recommend that you not kind of overdo it. So we want you to be gentle about what you do. God gave toddlers legs so that they can use them. So let your toddler run around and they can come to you. If you're trying to get pregnant very soon, you're not going to be able to lift the toddler every 5 seconds anyways. So this is a very good natural way of adapting your toddler to their new and upcoming reality. So we don't recommend heavy lifting or straining. If your toddler is a feather, sure, it's probably not a problem. But if your toddler is like most toddlers and they're 20, 30 pounds, I'd probably avoid picking them up. You can sit down, have the toddler come to you, do some basic lifting, but you don't want to be doing a lot of up and down because it will end up causing strain. And we don't have any evidence for this, but by and large, most fertility specialists will tell you strain is not a great idea.
Does PCOS affect the number of eggs retrieved? Just watched a video on embryo math, wondering if PCOS has different stats.
Yeah, I mean, you're definitely going to make way more eggs when you're PCO. So PCO women have many more eggs. There can, in some cases, be some degree of compromise in the quality of the eggs, but not always. And so PCO women definitely alter and skew the math because those stats represent averages in the studies that I included in that video. But the reality is that some women fall outside of that. So you might have, and I've had this, a 40-year-old woman that can produce 20 eggs. The average is 3 to 9. So if you're making double or triple or quadruple or whatever the number is of the average number of eggs, you're definitely skewing that whole equation, and you've got to factor that into the math for sure.
Why is getting a SCH so common in IVF pregnancies? Can anything be done to prevent getting SCH or preventing the SCH from getting too big?
There's nothing you can do to prevent a subchorionic hemorrhage. So for those of you that aren't familiar with the terminology, SCH stands for subchorionic hemorrhage. So you've got your sac. Outside the sac is the uterus. And then in between the sac and the uterus is a potential space. When blood collects in there because of detachment, that can cause subchorionic hemorrhage. So can we avoid it? No. Obviously, there are some things that can cause it. Trauma, fibroids, severe strain or heavy lifting, smoking, any kind of cocaine or drug use, anything like that, sometimes an abnormal shape to your uterus. So anything like that can increase your chances of SCH. Is there something you can do to decrease it? Well, take it easy. Don't lift anything too heavy like we were just saying. Obviously, avoid all the bad stuff. No cocaine in pregnancy. No smoking whatsoever. Smoking is the #1 cause of SCH. So you definitely want to reduce your risk factors, But there's nothing, if you're being healthy, you're avoiding all the bad stuff, there's nothing you can do to reduce your chances. Why is it so common? It's actually not just common in IVF pregnancies, it's kind of common in all pregnancies. IVF pregnancies are probably a little bit higher risk. Technically, we don't qualify you or put you into the diagnostic criteria of being a high-risk pregnancy, but I'd argue that you are higher risk than a normal pregnancy, and so you do need that extra level of TLC and care. And the reason for that is we do see some of these things more commonly: preterm labor, small for gestational age, subchorionic hemorrhage, and many others. Great question.
Had a live birth from first FET PGS normal embryo. I had 2 more
Awesome.
PGS frozen embryos. Do I have a high chance both embryos will implant?
Yeah, you've got probably, depending on where you're working with, you have somewhere between a 50 to 70% chance your embryo is going to implant each one. So yeah, you've got very good chances. 2 genetically normal embryos gives you an 84.1% chance of a live birth. So you should have a good outcome.
I did a sono August 2020 and retained placenta tissue was found and removed via hysteroscopy.
Yeah.
If I plan to transfer September 2021, should I repeat the sono?
Well, that's almost a year. So yeah, I mean, that's over a year. I would definitely recommend a repeat sono. And if you had retained placenta, there's a very high likelihood there is bacteria in your uterus, which is why we recommend Fertility testing to analyze and see if there's infection in there, because if there is, you very much need that out of there before you do an embryo transfer, or you could be wasting an embryo. So I would explore the possibility that there is some chronic endometritis via actual bacterial testing rather than just a biopsy, and we use Fertility for that. I don't own anything from them. I don't benefit from it in any way. We only use them because they're actually the least expensive and they're good. I'm actually not familiar with anybody else who even offers it, but if there are other places anyone knows about, please share with the group. We'd be open to anybody that's doing this and that's more local, like in Canada and the US.
Got some serious stats for you.
Oh yeah, okay.
40 minus 40, 0.40, I don't know. 40, I got 40. Oh, 40 years old, that's what it is.
Okay.
40, obviously. AMH 3.37 picomoles.
Okay.
ACF 8.
Okay.
Doing first round of IUI with Perjon and Letrozole.
Yeah.
Should I do a double trigger when I naturally surge to increase chances of pregnancy, or let the clinic decide? And then follow up, same
So-
viewer. How often before and after an IUI should one have intercourse to increase the chances?
Okay, so question number 1, you should have a double trigger, because double trigger does increase your chances of success. So we've actually reviewed that on the show. It'd probably take us a while to find that right now. But if you go through our YouTube channel, you'll find the link. What one was that called? I think it was actually called Double Trigger. So check that video out, because we did review that on the show, and there is a benefit to a double trigger. With regards to the second part of your question,
How often?
How
before
often?
and after,
So yeah, you should have sex every 2 days the entire month, around ovulation every day. And there's a study coming out, which I'll probably review very soon, which shows that sperm actually increases the uterine lining's immunological tolerance of an embryo. So it's not just important to have sex, you actually have to get them to ejaculate inside you without protection, because that ejaculate is actually potentiating the ability for the embryo to implant. So have sex every 2 days unprotected the whole month long, and around ovulation every day. The day of an embryo transfer, we usually tell people to take it easy, but the rest of the time you should. So like the day before an embryo transfer, have sex, and the day after, as long as you're not going crazy, leave the 50 Shades of Grey kit under the bed, kids. You'll be fine. You should try again. Definitely help things.
No question here. I just absolutely love you. You are the best doctor ever, and I am so thankful for you.
Is that my wife saying that?
No.
Well, thank you to whoever that is. I don't get to see who you guys are. I'm literally staring at a camera here, but thank you very much. That is very kind of you and much appreciated. We love doing this. Tarek and I really look forward to this day. We love helping everybody, so this is a great opportunity to reach out and help people out. So thank you for that very kind acknowledgement. We appreciate that a lot. I'm not going to say we do it for the pat on the shoulder, but I don't think either of us will turn down a nice pat on the shoulder. So thank you. Yeah, very much appreciated.
Do IVF babies born from the same egg retrieval look more alike because they are the same genetic makeup?
Oh, wow. That is a phenomenally good question. No, not whatsoever at all. So keep in mind, every IVF baby is coming from a separate egg and a separate sperm, unless they obviously naturally split into identical twins. So that egg has its own genetic makeup, and the sperm has its own genetic makeup. And when they mix, they then combine and recombine, and all sorts of things change over. So there is no reason to anticipate that IVF babies will look any more alike than natural babies would. It's going to be the exact same. The degree of variation will be the same. Super cool question. I've never even thought of that before.
I didn't know how to answer it. That was something for me. Hormones that you need to check before IUI or IVF.
Before, so if you're talking like in the diagnostic phase, FSH, LH, prolactin, TSH, thyroid antibodies, and then we check your testosterone and sometimes your DHEAS, DHEA. So those are the hormones we look at. And then we check your AMH level to make sure that you've got an appropriate AMH level. We check, and that's to test how strong your ovaries are. We check your iron, we check your blood type, we look at your sexually transmitted diseases, we do vitamin D. Those are the majority of the ones we take a look at.
I have consulting with you. Would you be the one doing the consult, or do you have other doctors, nurses doing it? And how often would I expect to talk to you on an ongoing basis if we're doing IUI, then IVF?
So it's always me doing the consults unless you are placed with Dr. Mayrand, who is my colleague, and she works with me. But we kind of have two streams of patients, and you're welcome to talk to me at any point in time. Even the patients that consult with Dr. Mayrand still talk to me about their choices and options when we go through the treatment, but she's trained with me. We literally use the same letter, it's the same history, and we go through all the same discussion. So when you're getting her, you're really kind of getting me as well, and she's lovely. So I do the vast majority of the consults. In terms of meeting with me again, we'll go over all the results together, and I do that for all my patients and all of the patients here at VRC. We go over all of the results together. We review every single point. I give you all of the numbers, all of the findings, every data point we have. We review it in detail for both you, and if there's a male partner involved, your male partner. And then we give you all of your options. Once you've selected an option, then we kind of hand you over to our nursing team, and whoever is appropriate for whatever you've chosen will take over. But I am always available, and we frequently will re-meet with you if you have questions, if you have concerns, or when there's failures. So if your IUI doesn't work after a couple of tries, I insist that I meet with you again, because I want to make sure we know what's going on and for you to know what your options are again. So we constantly keep that dialogue open, and I am always available to you. And certainly for patients that have questions, I actually don't want you to go through with treatment. I want you to feel very, very comfortable with what you're doing, both before you go through it and as you go through it and after you've gone through it. I want to make sure that you feel 100% satisfied with the information that I personally have provided you. So I take that oath very seriously, and we make sure that we're there for you. Yeah.
Okay. Does the use of HCG injections help with weight loss?
So apparently yes, and I haven't looked that up for a very long time, but there is some data that seems to support the concept that HCG does improve weight loss. So for people that are trying that, it's probably harmless. I say probably because there are no long-term studies. But I know many weight loss clinics actually use that as one of their tools in their armamentarium of how they help people lose weight. And I've actually had many patients do it and they've done very well on it. So yeah, it does appear to facilitate that. Now, how it does that, I don't know, although I have a suspicion. TSH, which is your thyroid hormone, and HCG share the same alpha subunit. It's two parts. There's an alpha and a beta subunit. And because they share the same alpha subunit, if your beta is really high, it does have some thyroid-like activity. So, for example, women that get molar pregnancies where their pregnancy is actually like a tumor instead of a baby, and they have incredibly high beta HCG values, like in the millions, they will get hyperthyroid because the alpha subunit is actually activating and acting like the TSH molecule. So in that scenario, probably there is some increase in your metabolic rate as a result of the beta HCG acting like thyroid hormone. Because I could just give anybody thyroid hormone, overdrive their thyroid, and they'll also lose weight because you're speeding up your metabolic system. I think this is the more gentle way of achieving that, but that's probably the mechanism by which it works, but we don't actually know. Back and forth, back and forth.
Yep.
Instagram, YouTube.
Okay. My last egg retrieval cycle, my doctor had me on max dose of Recovel and Menopur.
Okay.
Only retrieved 2 eggs. He said for the next retrieval, he'd add growth hormones. What are your thoughts?
So that was tonight's topic. So if you were watching earlier, growth hormone doesn't increase your live birth rate. You will get more eggs. And you'll actually increase your clinical pregnancy rate, but you're not going to get an increase in live birth. So my advice would be, if you need max dose to get just 2 eggs, stop taking any medication, do 2 cycles of natural cycle IVF. You're going to get the exact same outcome, and probably even cheaper if you're taking max dose hormones. And your egg quality actually tends to be quite good when you're not taking such high doses of hormones. So I'm a big believer in doing what's right for each patient. I don't believe one shoe fits all or one size fits all. Like we always say here, we're making babies, we're not baking cookies. This isn't cookie cutter medicine. So to just pound you with more and more medication, super expensive, that is not helpful for you, actually doesn't make any sense. You probably should go the complete opposite direction, do 2 natural cycles. You're still going to get 2 eggs with a minimum of meds, and usually the embryo quality and the egg quality is excellent. So that would be my recommendation. Growth hormone does not increase your live birth rates, and that is very, very well clearly delineated. And that data that we shared tonight is 2020. So when you go back and watch the start of this video, you'll see this is a 2020 meta-analysis of all the studies going back as far as, I think it was 1994 was the first one that they included. So definitely take a look at that.
For someone with an AMH of 3.4 picomoles at 40, what's the most aggressive IUI protocol? What's your IUI success for someone like me, no male factor, what to do to increase IUI success?
Okay, so most aggressive protocol would be injectables with like a Lupron flare and doing relatively high dose meds. That's probably not a great idea for an IUI, because if you get pregnant and you have too many eggs, you could turn into octomom. So if you're the same reader that asked earlier, or watcher that asked earlier, you had 8 antral follicle count, I would not overstimulate you to produce more than 3 or 4 eggs, because you do risk running into having triplets and quadruplets and so on, or even more. So very aggressive would be shots, but you've got to be relatively tame about how much you take. The second part of that question is there something you can do to increase your IUI success? There are loads of things you can do, but keep in mind, at 40, after 3 tries of IUI, you have about a 15% overall chance of success. So even if I increase that by, let's say, 30%, I've only increased you from 15 to, like 20%. So it's not like you're leaping forwards in terms of success. And we don't have anything that improves IUI by 30%. What kinds of things can you do? So avoid all the bad stuff, no smoking, no drinking, no drug use, keep your weight in control, make sure you're topped up on all your vitamins, in particular vitamin D. You should be taking melatonin, lots of antioxidants. We would probably advise doing Zymo if there's any chance of high sperm DNA fragmentation. And then, obviously do the shots. That'll increase your chances, but keep in mind it'll also increase your chances of having multiples. But is there something you can do that will take your 5 maybe 6% chance per month and all of a sudden make it 20%? No, there isn't anything that we can do that does that unless you move to IVF.
When you do a laparoscopic surgery for endo, do you do ablation or excision?
I do whatever is indicated based on your anatomy. So we often excise if it's in a location that is amenable to excision. And sometimes we ablate if it's in a really dangerous location. There is a whole movement out there that I am very keenly aware of that has people believing that you must excise and that ablation is not good enough. That's just scientifically not true. So they've actually done direct head-to-head studies of ablation versus excision, and there is a 1-point difference in the pain score, which is not clinically relevant. And we're not talking like out of 10, we're talking like out of 100, there was a 1-point difference in the pain score. So there's no, that's not even, outside of the realm of, being able to detect it. It's so far out that it's not going to be clinically meaningful. So there is no reason to believe that we must excise every lesion. That's just simply not true. You need to control the endo, and that means getting rid of the endo. But if you have someone that knows what they're doing and is going deep enough with an ablation, there's no reason that you have to excise every lesion. And some of these can be dangerous. I mean, if you're excising around the ureter and you don't know what you're doing, and quite frankly, many surgeons don't, that's a dangerous thing for you because you can get injured, and that's a bad injury. So it's very, very important to make sure that your surgeon is an expert, and as well that they are doing what's clinically indicated for your specific case. In our endo video from way, way back, you can see me cauterizing some and you can see me removing another. So it varies from case to case depending on how deep it is, how thick it is, and where it's located. If it's sitting on your bladder and it's superficial, I might just remove it. But if it's deep, you can't just remove that because I'm going to injure your bladder. So there are anatomical considerations that are critical, and you need to have someone that's thinking about all of that when they're doing it.
Can a estrogen priming protocol result in fewer follicles? If yes, why?
It shouldn't. Could it? I'm sure everything could happen, but it shouldn't result in fewer. Actually, I can't think of any biological reason why it would. So typically speaking, no, unless you didn't take estrogen and you took birth control. Birth control can suppress you, but estrogen should not. So estrogen priming should not lead to reduction in follicles. It may not increase your follicles, but it shouldn't reduce them.
Does endometriosis affect egg quality?
Yes, 100%, very clear. Lots of studies that show that. That was an easy one. That was a gimme.
Sometimes you get those.
I know, every once in a while I get an easy question. You guys all ask great questions. It's nice to have like an easy one just to slip it in there. It's like when you're doing multiple choice and you're like, I know the answer to this one.
I've seen this before.
Yeah.
As a follow-up to the question regarding picking up your toddler, does constipation pose a threat as well?
Yeah, if you run constipated and you're really straining, it's no different than picking up a child. I mean, the key is you don't want to overly activate your core muscles, and when you're straining, you're activating your core, and that's compressing everything inside, which pushes everything down. And it does alter blood flow as well. So you want to minimize that internal pressure buildup. So whether you're constipated in your straining or you're lifting in your straining, quite frankly, it's kind of the same thing from a physiological standpoint. So without getting too graphic on air here, I would say yes, keep your stool soft. Restorelax is safe. Dulcolax, Senecol, Lactulose, they're all safe. You can use any of those.
Is it normal to have a period while you have a positive pregnancy test?
No, definitely not normal. You either have a pregnancy that is not in your uterus, or you are bleeding because you either have a hemorrhage or there's a miscarriage. So it is 100% not normal to bleed in pregnancy. People say all the time, oh, it's normal to bleed. It is never normal to bleed. It's common, but it's never normal. So if you're bleeding, you're either miscarrying, you're hemorrhaging around the pregnancy, like the subchorionic question that someone asked earlier, subchorionic hemorrhage, or you've got an ectopic and you need to deal with that right away. But it is never normal to be bleeding in pregnancy. You should go and be seen right away, please.
What are your thoughts on IV therapy while going through IVF?
IV therapy? Well, if you mean IV like intralipids, I'm a believer because we've been using it for 13 or 14 years now and it seems to work quite well. IV vitamins, okay, so this is cool. We're just coming out with this in the next few months at our 2 sites, soon to be 4 sites actually. So IV vitamin therapy may actually have a very significant benefit. So a naturopath we're working with out of Sarnia, Dr. Shi, does IV vitamin therapy, and we were discussing it and I thought, I'll go check this out because he was a real proponent. So sure enough, there is data that shows that your live birth rate is correlated with the concentration of vitamin C in your follicular fluid at the time that we aspirate your egg. So obviously delivering that to you IV will get a higher concentration into your bloodstream and therefore into your eggs and everywhere else. So we're actually going to bring that on board. So I am a believer for things that have scientific proof, and it does look like there is some proof to that. I don't know about all the vitamins and all the supplements, but I just started looking up, the first ones I could. Vitamin C cropped up, and sure enough, there's a good trial there that shows that it is beneficial. So I'm a believer for intralipids. I'm a believer for the IV vitamins. Any other IV therapies? It would depend on what you're talking about, so I'd have to know.
After taking folic acid and aspirin, is it normal to have period 1 week earlier than the usual cycle?
No, that has nothing to do with your aspirin or your folic acid at all. Could be stress, could be hormones, could be that you're pregnant and you're bleeding, could be implantation bleeding. There's a variety of different things. So that is not related to folic acid or to any vitamins or anything like that, no.
When taking Lupron for endo, how long should it take to start feeling some pain relief?
So the studies show that your pain relief will peak around 6 to 8 weeks after you take it, but the first week you shouldn't notice very much, and then you should start to feel some reduction in pain after taking the Lupron shot. But it takes 6 to 8 weeks to kind of maximize. And then after about 10 weeks, you might start feeling it come back as the effect starts to wear off gradually. So we often have to give you the next shot if you're staying on it. And remember, at some point you need add-back therapy. You can't be on it for more than 6 months without having at least some estrogen put back into your system.
I had a failed fresh transfer followed by a period. Now, my next cycle is delayed. Would you recommend Provera or waiting for the cycle to regulate naturally?
It won't make a difference, but query as to why your cycle's delayed. So make sure you repeat your pregnancy test first and then get all of your hormones checked, because an IVF cycle should not delay your period if you failed the transfer. So get that checked out, make sure you know everything that's going on, and make sure you're off all of the meds that they put you on, because that can delay it. So a lot of times people continue estrogen and progesterone for a while at various clinics in order to not have people start their period before the weekend, so that people aren't calling on the weekend scrambling for what to do next. We don't do that here, but we actually keep you on your hormones until your preg test, and then we just tell you to stop. But it's important to make sure that you're not on those meds, because it will delay your period.
Is there anything particular you do or change during your transfer protocol when a patient has a retroverted uterus?
Yeah, we do a transvaginal ultrasound guided embryo transfer, which is awesome. So actually we were chuckling about it the other day because as my embryologist was doing the transfer with me, I said, who could get you a picture this good? So transvaginal ultrasound guided embryo transfer is truly, truly an art form. It is very difficult to do. You have to be very good at ultrasound because you're holding the outer catheter in one hand and you're holding the ultrasound probe in the other, and then your embryologist is bringing in the embryo to load. If you have an ultrasonographer with you, they could do it, but I like doing them myself because I'm very hands-on and want to know exactly where the embryo is going. So it's a very, very difficult thing to do, but in contrast to the absolute, quite frankly, crap that you see when you're doing a transabdominal ultrasound guided transfer for a retroverted, especially retroflexed uterus, with a transvaginal ultrasound, it is crystal clear. I mean, it's better than what you see when you have an anteverted uterus and you're doing transabdominal. It is absolutely crystal clear. So we use a transvaginal ultrasound probe, and we use a approach like that, and we can see exactly where the embryo is going. And I actually think that the success rates are higher than a transabdominal, but time will tell. No one's done the study yet. Maybe we should. Great question.
My doctor said my cervix is nearly closed and I will need a surgery prior to transfer. I haven't received details of what this surgery will entail. Can you explain?
You're dilating your cervix, that's all. They're going to stretch your cervix by putting these metal devices that get increasingly wider. So they start out around like 1 millimeter or even smaller, and then they sequentially go up. And you don't need to get too wide, but if you're up to like a 5 or 6, you can easily pass a catheter. Sometimes we'll over dilate to make sure that we're getting it big enough that it won't shrink down again. So that's all they're going to do for you. It's called a cervical dilation. It's generally speaking harmless. It's pretty difficult to do something damaging from that, although you can perforate the uterus if they're not doing it right, or your uterus is really retroverted and they're sticking in the dilator this way, because you can go right out the back. So as long as they know what they're doing or are using an ultrasound guided dilation, you should have a very safe, easy path forward, and it can be done under conscious sedation or under a general anesthetic or even a regional block. There's all sorts of different options.
Hello, my favorite doctor. My doctor prescribed me DHEA 50 milligrams per day. My last results show
that's a high dose.
My last results show that DHEA is now 9.98.
Yeah, don't worry. Yeah.
And it is over the range of 1.65 to 9.15.
Right.
Should I continue taking it? I read that too much DHEA can harm egg quality, and I already have low AMH. Thank you. So
I'm not a believer in DHEA that much, because it actually has also, like human growth hormone, not been shown to increase live birth rates. So I'm not a big believer. You are on a really high dose. We usually only use 25 3 times a day. You're on double that. I would be questioning the wisdom of why you're on that much, and it likely is not going to be beneficial. So I would back off of using that much DHEA. Probably cut it in half. As to whether or not it'll help you, the data does not support DHEA being beneficial. So I stopped using it a while back. We occasionally still use it, but we find that testosterone priming does the exact same thing with way less side effects, because DHEA you need to be on for 3 months before you do your cycle. In that time, you're getting acne, hair growth, oily skin, probably some weight gain. Testosterone priming we do for like 2 weeks. So it's a much shorter window with way less side effects. Yeah.
After finishing a long course of antibiotics for bacteria in the uterus, should we be using this next cycle's menstrual blood for fertility retesting, or should we be waiting for another month?
No, use this one. That's perfectly fine, because we want to see if you got rid of it.
My last 2 HCG beta results were 2971 at 16 days past 5-day transfer, then 46.
Then 46?
Yeah. Then 46.
So unfortunately, that's a pregnancy loss. I'm so sorry. If your beta is going down, it means that the pregnancy is not moving forward, or at least is not moving forward correctly. 16 days post 5-day transfer, something in the 200s would be considered a little bit on the low side. So for sure, that's not headed in the right direction. Please be safe. Make sure you don't have an ectopic. I actually just operated on a patient of mine whose beta went up to 150 and then actually went down to 70 or in the 70s, but she still had an ectopic. So make sure you're being safe at all times. Check, double check, triple check. Never take chances with this stuff.
So 2 questions later, that same questionnaire.
Yeah. Yeah.
Oops, my last HZ beta result was 2691 at 16 days past 5 days transfer. Then only 4,693 48 hours later. How concerned should
Okay,
I
that's
be
a
about
wildly
metabolic
different
increase?
result. So you need a minimum of a 60% increase. So 60% at 2,700 would be 420 and 1,200, 16. So 16 and 27, so 4,300. What was it?
4693.
Yeah, so you're in the right range. So if you went from 2,600 to 4,600, you're right on the borderline. So I'd maybe be a little concerned, but definitely continue following. But 260 down to 46, that's definitely going in the wrong direction. But from 2,670 out to 4,600, you're right on the margin of what we would consider normal.
Would you risk surgery to remove a cyst from an ovary when you only have one ovary and to severe endometriosis?
It depends on what the cyst is. So if it's a simple cyst, no. If it's a cyst of endometriosis and it's getting bigger, you are damned if you do and damned if you don't. And here's why. If you remove the cyst, you will have a weakened ovary. There are multiple studies that have shown that. In particular, if you don't get a good surgeon to do the surgery, you'll definitely end up with a weaker ovary, because a lot of people go in there and start cauterizing all of the bleeders, which then leads to diminished ovarian reserve for sure. But at the same time, if the endometrioma is getting bigger, or any kind of cyst, it puts so much pressure against the outer wall of the ovary that it's compromising the blood flow. So if you're compromising the blood flow, you're also getting diminished ovarian reserve. And there are studies that have shown that too. When you have an endometrioma, even before the surgery, your AMH is taking a hit. So I would definitely caution you to have a long discussion with your surgeon, number one. Have a long discussion with your reproductive endocrinologist, number two. Ideally, if your reproductive endocrinologist is an exceptionally good surgeon, and I want to emphasize, exceptionally good, then let them do the surgery, because we're, in my opinion, more mindful of the fertility component of what we're doing. No disrespect to any gynecologic surgeons out there. We just are so focused on the fertility part, we're extra cautious. And then have that discussion and see what's right for you. But most REs don't do a lot of surgery anymore. I'm like one of the few that still does. And a lot of gynecologists don't even know that if you burn the ovary, you're killing the egg. So you got to find people that actually know what they're doing, know the anatomy, know the techniques to use to preserve as much of your ovarian function as possible. That's a critical question we face on a daily basis. And I always kind of put it on the scale of, am I going to do more damage by doing the surgery, or am I going to do more kind of saving of the ovary by doing the surgery? And you have to decide for each individual case. Tough case though. And I would tell you this, I would not do the surgery unless I was prepared for the possibility that you may need donor egg, because you only have one ovary left. You could run into problems with bleeding. You could run into problems with damage to the ovary. They may need to remove it. There may not even be very much normal ovary left if you wait too long, in which case you have to be prepared for the need for donor egg.
At 43, got 6 eggs, 2 fertilized, will test. 300 gonal, 150 metaper, 5 letrozole, overdrill. Despite my concern on BC, to doc says it's okay. Northwestern Chicago thoughts for next cycle. They don't do dual stim.
Northwestern doesn't do duostim? That's crazy. Eve Feinberg is at Northwestern, and she's probably one of the smartest people I know. So talk to Eve, because she's at Northwestern. I would recommend you go half-half with your ratio. So instead of 300 gonal, 150 menopure, it should be 225, 225. Tarek's vigorously nodding off camera because he already knows that. There you go, yeah. I'd make sure you did a double trigger if you didn't before. And then in terms of, what was the thoughts of?
Thoughts on the next cycle. They don't do dual stim.
Oh, I mean, you got 2 embryos, which is reasonable. I would do it again. Depending on how many antral follicles you have, I would consider doing duostim. I'm sure they'll do it for you. You just have to say, I want to do duostim, and then get them to give you a price for it. I'm shocked to hear they don't do that. But that's a reasonable approach. Now, birth control, if you're 40 with a low antral follicle count, I would argue you should not do that. It will, in some cases, suppress you, and it doesn't in every case, but it does in some, and I'm just not willing to take that risk for my patients. So we don't use it when you're over sort of 38, 39, or you have compromised ovaries. We avoid using the birth control pill for those patients. The questions are endless.
Yeah. Seriously. I scroll here and I said, you know what? I don't know.
Okay, next.
Okay. How can I get rid of fibroids without surgery? And my AMH is 1.77. How can I increase my egg count, or can I get pregnant with 1.77 AMH?
I'm going to answer those backwards. You can get pregnant with any AMH. It's always possible. It just gets more difficult the lower your AMH goes. You cannot increase your egg count. It's actually biologically impossible. There can be little fluctuations, but you're not going to go from having 2 to 10. You might go from 2 to 3 or 4, but you can't actually increase your egg count. How can you get rid of your fibroids without surgery? That is not possible. The only thing you can do is stop them from growing, which can be done with medication or high-frequency MRI-guided ultrasound. But you cannot get rid of fibroids with any technique from anyone, anywhere, no matter what they say, without actually operating.
I took the trigger shot and IUI tomorrow. After I did take the trigger shot, a couple hours later, I noticed a thick egg white, stretchy cervical mucus.
Sure.
Does that probably mean I have already ovulated?
No, you know, the correlation between your assessment of your cervical mucus and ovulation is quite weak. There's one study coming out that says it's reasonable, but most of the studies say it's fairly weak. So it would be unlikely you've ovulated, especially if you were taking a trigger shot, because you wouldn't trigger unless you were being monitored. And if you're being monitored, then it would make sense that they would know if you were ovulating or not, but definitely go over your results and make sure it hasn't happened.
If you have IVF, can you choose to have 2 embryos implanted?
Can you? Yes. Should you? Depends on what your age is and whether or not you did genetic testing. But as a general rule, we try for only 1 at a time. Our program right now has such exceptionally high success rates. I'm actually very worried when I'm putting in 2, because everybody's going to come back with twins because our rates are so high with our program. So with just 1, we're getting so many of our patients pregnant. I don't want to put in 2 because twins is a high risk pregnancy. So we very strongly try to avoid that. Yeah.
I'm 44 years old and did 2 egg retrievals. I got 10 mature eggs and 12 mature eggs.
Awesome. How old?
44 years old.
Wow. Congratulations. That's amazing.
They said eggs were dark and granular. Do
Yeah.
you know if the embryos can be good quality dark and granular eggs?
Dark cytoplasm or dark center and granular or vacuolated eggs is definitely going to compromise your embryo quality. It doesn't mean you can't get pregnant or that you won't have good embryos, but it does make it harder. That's the belief amongst the embryologists, and there are studies to back that up.
Is red light therapy safe during the 2-week wait in pregnancy?
Red light therapy, if you mean going to the red light district, no. If there's some other kind of red light, I am not familiar with any red light therapy. I would have to ask somebody that does red light therapy. I don't even know what that's referring to. I've never heard of it before. You got a headache?
No, just suddenly, I don't know. I can't figure it out.
Okay. He's rubbing his head off camera.
No, I'm good.
Okay.
How much does it cost for IVF with egg donor with drugs too?
It depends on what you want. We have different packages available. We have like a conventional package, we have multi-cycle packages, and then we have live baby guarantees. I tend not to get into pricing issues online here because we don't want this to turn into an advertisement for us. We're really just talking about your general well-being and your fertility journey, but you're welcome to reach out to me online. You can email info@drvictory.com, set up a time to chat, and I'll happily go over the pricing with you. I would say in general, your pricing is going to be anywhere from about $13,000 on up. And it can go up to 40,000 or 40,000 plus if you want like a 2-baby guarantee, but it starts quite low and then it builds up from there.
My RE has subscribed estrace for after my transfer. I read estrace is not safe for pregnancy. What's the purpose of estrace in a protocol? I'm at CD6 of med. I plan to do a day 3 transfer.
So estrogen's there to thicken your lining. We personally have started moving very much away from estrogen because the more natural your cycle is, in some regards, probably the higher the success rate and the lower the complication rate. And the active bad agent in that is estrogen. So we have supplanted estrogen with letrozole, which has been clinically proven to improve your success rates. And so we avoid the estrogen. Having said that, we do need it sometimes for the women where their lining just won't thicken. And the idea behind it is to thicken and then support your lining until the hormones in the pregnancy can take over and do what they need to for the lining themselves. So that's why you're using it.
Our IVF failed. We have 2 embryos. Both did not take. My doctor said I have endo and recommend to go on Vizan for 6 months, then try naturally. Unsure if this is a good approach or will we need IVF again? Or we will need IVF again.
Okay, so I don't know if you'll need IVF again. It's certainly possible you would need IVF again. Vizan for 3 months prior to your IVF cycle has been shown to improve your results of an IVF cycle. We actually don't allow transfers or well, I don't want to say don't allow, but we try vigorously to avoid transfers for patients with endometriosis fresh ever. We always do them frozen because a fresh embryo transfer into a patient with endo, in my mind, is physiologically nuts. It makes no sense whatsoever because your endo is maximally activated at the end of a stimulation cycle where your estrogen levels are high. So you want to wait until you're doing a frozen. And there's one very good study looking at unexplained infertility where 3 months of Lupron with letrozole significantly increased the chances of success, like hugely increased them. And the theory behind it was very obviously most of those unexplained patients probably have endo. So by giving you Lupron and letrozole for 3 months between the creation of your embryos and the transfer of your embryos, you will see a statistically significant improvement in your success rate. Whether or not you need more IVF or should you try 3 to 6 months of Vizan and then IUI or something, that's up to you. The alternative is to do surgery as long as you get a good surgeon and get rid of the endo where possible and if safe for you and cost effective and so on.
904.
What do you want to do? One or two more?
Yeah.
Do you have a doozy of a question?
I think I have a doozy.
You got Tarek's question. We're going to call this from now on Tarek's. What we got to have a name for this.
Oh, the tough last.
Tarek's terrific question. Yeah.
Let's go for it.
All right, go for it.
The pressure.
The pressure. He's sweating bullets off.
Okay.
Yeah, fire away.
Yeah. Well. Okay. Yeah. Here we go. I got one for you.
Okay.
I'm 39.
Okay.
AMH 1.95.
Picomoles or nanograms?
Unspecified.
Okay.
Open tubes.
Okay.
And no underlying health conditions.
Okay.
I've had 2 failed IUIs.
Okay.
Do you recommend moving on to many IVF in voxel? I'm using donor sperm as a SMBC.
Do I recommend going to IUI in what?
Do I recommend moving on to mini IVF in
Or to
voxel?
in box?
In vox.
In vox.
INVOXELL.
Oh, Invocell. No. So Invocell actually doesn't have much of a higher rate of success than IUI does. I never recommend Invocell. I would not do mini IVF. I would go for a maximal stim, not maximal, but like a normal stim IVF cycle in a lab and not Invocell at all. Invocell has about a 20% success rate. If you are 39 and you do 6 cycles of IUI, you have a 30% success rate. It wouldn't make sense to even do the Invocell. You should just keep staying on the IUI. So IVF is reasonable. I would normally say after 3 tries, but if you're using donor sperm, there's a financial crossover point where spending the money on more sperm samples actually starts to tip the balance towards an economic kind of benefit to just doing the IVF. So I would be cautious about that one for sure, and analyze the numbers financially for yourself, but don't do Invocell. Invocell's a waste of time in my opinion. The studies do not validate that the success rate's high enough to justify what you're doing, and it doesn't make sense. Mini IVF versus a full stim, listen, at 39, the more eggs you get, the better off you are. So mini stim has been shown to give you roughly the same results. There's nothing wrong with trying a mini stim, but there's lots of data out there that shows the more eggs you get, the better off you're going to do. And we reviewed that 2 months ago. We had a mini stim versus normal stim video, so check that out. You'll see it there.
I think I got one.
Oh, you got another one. Tarek's on fire tonight, guys. Okay, one more. 907.
And I just want to know, was it a typo, the Invocell? Or
It's INVOCELL.
Okay, I think so.
Did it say Invox cell?
Yeah, I just wanted to make sure.
Yeah,
typo where I can't read it.
No. It's INVOCLL. Invo and then the word cell.
Okay.
Yeah.
So get ready. A lot of numbers coming up. Was currently on 10,500 IU of delta pairin.
Delta parent. Yep.
Yeah, for reoccurring PEs.
Okay.
Diagnosis still unknown. Went for a second opinion in London, and doctors suggested going back to a pill for anticoagulants.
Yeah.
I was originally told while actively trying to conceive I must remain on injection.
Right.
Your thoughts? Should I remain all delta pairin opposed to switching back to pill form while actively
Yeah,
conceive?
none of the pills are safe when trying to get pregnant, so you got to go back to the injectables. None of the pill forms like apixaban or any of those things are safe for pregnancy yet, so you have to be on the injectables. That was a gimme.
There was a new word in there.
All right, guys.
Some vocab, you know.
All right, guys. I think we'll wrap up the show now. It's 9:09. So thank you again for joining us. If you didn't get your questions answered, don't hesitate to send them in. We'll find a way to answer them. We're always happy to help. Make sure you like, comment, and subscribe on our Instagram channel and on our YouTube channel. I wish to God everybody out there would help the Instagram channel grow. I still swear that you must twerk on Instagram or you cannot make the channel grow, and I refuse to twerk. So, nor would anyone ever watch our channel again if I did. So make sure you like, comment, and subscribe and share with your friends, and hit that subscribe button. We want to have more followers and more subscribers. Anything you see here, you should be able to find on Instagram in our IGTV section within a week or two, and on our YouTube channel shortly as well. Have a great night, guys, and stay safe.